So, welcome everybody, distinguished group. I'm not sure I'm going to enlighten anybody in this audience, man. These are my conflicts. I have nothing that will be relevant this morning. Everybody knows about the appropriate use criteria that have been published starting back in, actually before 2009 with other things, but 2009 or 2008, 2009 with the coronary revascularization and a recent update. We all are aware of what went into that. AUC scoring was done by a technical panel on a series of scenarios, and as to whether people felt this was appropriate, uncertain, or inappropriate. And of course, everybody knows that the criteria now have been changed, or not the criteria, but the terminology has been changed to appropriate, sometimes appropriate, and rarely appropriate. And those exercises created grids that look somewhat like this, depending upon the scenarios that were defined. And the A's, of course, mean appropriate, the U's mean uncertain, and I's mean inappropriate. In addition, the AUC documents led to sort of an algorithmic approach as well. For example, in this case, patients with STEMI and cardiogenic shock. You could go down a series of pathways to find out what was an appropriate strategy or an inappropriate or uncertain strategy for those patients. And these were all voted on. So what about in arenas other than the coronary arena? There have been appropriate use criteria recently published, not quite a year ago, for peripheral vascular non-invasive testing. And this is led by Emil Moeller, with, again, a technical panel. And these are some of the grids that were created from that AUC document. And for example, this is in the evaluation of cerebrovascular disease, when to do a carotid duplex ultrasound. And you can see there are a series of different scorings based on the condition. So for example, if the patient has no cervical bruit but a history of neck irradiation more than 10 years ago, that would be an uncertain indication, asymptomatic. If